77 years old, ischemic stroke last month, known AFib, plus a 70% carotid stenosis. So he's on an anticoagulant for the AFib, but that stenosis is a ticking time bomb. Do we add an antiplatelet?
Welcome. This is the tightrope walk we face every day in stroke medicine. You see, we have a patient with two completely different reasons to form a clot, and our first instinct is to treat both of them aggressively. Today we're going to break down a landmark trial that really confronts this exact problem. It gives us the first high-quality, randomized evidence to help guide our hand.
We're looking at the AATS-NBF trial. This is the very first randomized study to tackle this specific super high-risk population. So let's see what the investigators found out.
Now, to really get this trial, we first have to appreciate the profound clinical tension these patients represent. It is a classic case of two pathologies, and each one demands a different solution.
So picture a balancing scale. On one side, you've got atrial fibrillation. That's the arrhythmia that can form clots inside the heart and just shoot them right up to the brain. And our weapon of choice for that is an anticoagulant. Now, on the other side of the scale, you have atherosclerosis, the hardening and narrowing of the arteries themselves, which can rupture and form a clot locally. And for that, we typically use an antiplatelet. The AATS-NBF trial was designed with a very elegant and simple question in mind. Does using both of those weapons at once actually help us win the war, or does it just end up causing a lot more collateral damage?
So investigators in Japan enrolled 316 patients who had recently had an ischemic stroke and had this exact dangerous combination of non-valvular atrial fibrillation and atherosclerotic disease. These patients were then randomized into two very clear groups. The first group got an oral anticoagulant by itself. The second group got that same anticoagulant plus an antiplatelet agent. So it's a direct head-to-head test of monotherapy versus combination therapy.
The investigators then tracked what we call a composite primary outcome. You can think of it like a clinical scorecard that adds up both the good and the bad. It includes ischemic events like another stroke or a heart attack, but it also includes major bleeding events. This approach gives us the net clinical benefit, and it tells us which strategy is really better for the patient overall.
The results were so clear that after a planned interim analysis, the trial was actually stopped early for futility. The answer was absolutely definitive.
When you look at that composite scorecard, adding an antiplatelet gave no significant overall benefit. Let's just quickly break these numbers down. The hazard ratio tells you the risk in one group compared to the other. A ratio of 1 means the risk is identical. So here, at 0.91, it's basically a statistical tie. And that high p-value of 0.64 just confirms that this result wasn't a fluke. The bottom line here is that combination therapy was not superior.
Now, what's really fascinating is when we dig into the different parts of that outcome. If you look closely at the curve for ischemic events on this slide, you can see the lines for the two groups start to separate a little bit. That suggests a slight trend, a tiny hint that maybe the combination therapy prevented a few more clots. But that gap never got wide enough to be statistically significant.
And this slide just brilliantly shows the cost. Any hint of benefit was completely drowned out by a shout of harm. For bleeding, the hazard ratio was 2.42. That means patients on combination therapy were more than twice as likely to have a major or clinically relevant bleed. And with a p-value of 0.008, this was a very real, statistically significant danger. The scales tipped decisively toward harm.
Okay, so this is some really powerful evidence, but to apply it responsibly, we have to understand the context of the trial and its potential limitations.
All right, first, the study was open label. That means everyone knew who was getting which treatment. That can create bias, although it's worth noting that the committee that judged the outcomes was blinded. Second, the physicians could choose which specific anticoagulant or antiplatelet to use. Now, this makes the results more real-world, but it also means we're testing a strategy, not a specific drug regimen. Third, the population was entirely Japanese. This is critical because there can be ethnic differences in drug metabolism and bleeding risk, so we have to be cautious applying this one-to-one in other populations. And finally, since every patient had AFib, standard stroke subtyping wasn't used, which makes it a little bit harder to know if the risk-benefit might be different in someone with, say, very severe large artery disease.
So, with all that context in mind, how does this actually change what we do on Monday morning?
Let's distill this whole thing down into 3 practical takeaways. Number 1, default to monotherapy. If you're a typical patient with AFib and stable atherosclerosis after a stroke, an anticoagulant by itself should now be the standard. 2, it's time to reevaluate. For those patients who are already on combination therapy, this trial has a trigger to critically question that choice. Does the risk of clotting truly justify this newly quantified doubled risk of bleeding?
And number 3, be extremely cautious with combination therapy. We need to reserve it for only the absolute highest risk cases, maybe someone with a recent coronary stent or severe symptomatic peripheral artery disease, and even then, only after a very explicit conversation about that significant bleeding hazard.
The study's authors really summarize it perfectly. What we all thought was a safety net turned out, for most patients, to actually be a trap.
It seems a powerful modern anticoagulant is enough to cover both the cardioembolic and the atherothrombotic risk in most of these patients, without paying the very dangerous price of adding an antiplatelet. So the next time you have this patient in front of you, before you just reflexively add that second agent, pause. Remember this trial. Remember that doubled bleeding risk. And ask yourself, does my patient's specific risk of another clot truly justify paying that steep price? Disclaimer and bibliography in the description.